So I'm delighted to welcome Iain Chapple. Iain is a professor of periodontology and consultant in restorative dentistry, and he's also the Director of Research for the Institute of Clinical Sciences and College of Medical and Dental Sciences at Birmingham University. So Iain is known both nationally and internationally for his research looking into the connections between oral and systemic diseases, and he was also awarded an MBE recently in recognition of his various research achievements. So hopefully this will follow on very well from Graham's presentation. And the title of Iain's presentation today is Death by Comorbidity, Does Periodontitis Play a Role? So thank you, Iain.
Thank you very much, Zoe, and I just want to start by congratulating Graham and actually everybody at Salisbury for putting this together. I think it's a fantastic initiative, and all the work you're doing is really quite tremendous. And thank you for the invitation to speak today. What Graham's asked me to do is to not focus on SARS-CoV-2, but to focus on the more general oral systemic links, which is what I shall do, because they will provide insights into some of the mechanisms Graham's already talked through in terms of the oral vascular pulmonary pathway. I just really want to emphasize how timely this is, because it's only 6-7 months ago that the World Health Organization essentially set a challenge to themselves, effectively, to develop by 2022 a draft global strategy on tackling oral diseases, and they've set quite a tight timeline of reporting back by 2031 as part of a more general report on non-communicable diseases. And actually, for those of you that browse or read the New England Journal of Medicine, you'll note the date on this, March the 3rd. That's actually today, and this is essentially a perspective guest editorial type of article on the importance of oral health in general health. So what I plan to do is to talk briefly about non-communicable diseases in an aging population. I want to talk a bit about the pathogenesis of periodontitis and how it is involved mechanistically in comorbidity and mortality. And then I'm going to briefly give you a summary of the consensus on periodontal atherosclerosis and periodontitis. And then, as Graham alluded to, he mentioned chronic kidney disease as one of many diseases that we've studied. I want to give you some data on the causal links between periodontitis and chronic kidney disease, because I think some of those mechanisms are relevant to SARS-CoV-2. So you'll all be very aware, well, I particularly am at my age, that we are an aging population. And aging is something that is actually genetically determined, but importantly, it's modulated by our environment, by our behaviours, by our lifestyles, etc. And I want to make that point because behaviour change is critical to any medical treatment, particularly for chronic conditions and for non-communicable diseases, and the role of the individual in behaviour change, and actually our role as healthcare professionals in behaviour change is critical to the success of any new intervention. So why have I chosen mortality? Well, I've chosen mortality because it's just, quite frankly, a title that grabs people's attention. But the truth is that there is in fact now quite a bit of data from different countries around the world on large populations demonstrating an independent association between periodontitis and premature mortality. The index study was really the one at the top there by Raul Garcia, which started in the early 60s, 1964, I think it was, and it's a study on the veterans in the USA, based in Boston, the study, and what it looked at was the risk of mortality over a 25-year period in relation to baseline levels of periodontal disease, baseline levels of bone loss. And what it demonstrated was if you had moderate to high levels of bone loss around the teeth, then your relative risk or your odds of mortality were increased by 85% relative to those who had no bone loss or very mild bone loss. And there are other studies in Northern Ireland, in Finland, in Sweden and other countries now using different designs but showing the same effect over different periods of time. The question is why? Well, one of the reasons behind that relates to periodontitis as a non-communicable disease. And the next slide I'm going to show you after this one on the pathogenesis or the pathophysiology. But non-communicable diseases are essentially major causes, the major cause of death globally, 38 million deaths, and 16 of those being premature. They're increasing in prevalence globally, partly due to the aging population, but partly due to our lifestyles, which have become more sedentary and more dependent on refined diets, high in refined carbohydrates, which fire off inflammation through various cellular pathways, which are fascinating, but I don't have time to go into, sadly. They will affect over 90% of older adults have one and NCD, and almost 80% have two or more, and we call that comorbidity, as you're aware. And in terms of periodontitis, well, 60% of people over the age of 60 have periodontitis. It remains the sixth most common human disease. So how may this be happening? What are the potential explanations? Well, one of the potential explanations is purely the anatomy. Graham talked a lot about anatomy, and I should say that the anatomy of the tooth and how it emerges through the skin of the mouth, the gingiva as we call it, is quite unique to the body. And I tend to regard the teeth as 28 bones sticking out through the skin, but that is their natural environment. And so this junction here is incredibly specialized. Now the skin will shed, and it will shed any microorganisms on the skin as a protective mechanism. It's part of our innate ectodermal barrier, if you like, whereas the enamel of the tooth does not shed, and therefore the biofilm, the plaque biofilm, builds up, contains multiple species, viruses included, and as it builds up, it irritates the lining epithelium, the sulcular epithelium here, and these cells send alarm signals into the underlying connective tissues, which generate an immune and an inflammatory response. And the early stage of that is what we call gingivitis. But the various processes here involve cytokine release, matrix metalloprotease release, and that leads to a breakdown of the intercellular adhesion molecules, and these tiny little craters, which are actually microscopic ulcers, develop. And these are almost like a rotating door. The blood can emerge from the connective tissues into saliva, so you see blood in your saliva when you brush your teeth. But equally, various microorganisms can enter the bloodstream almost like a hydraulic pump every time we eat or talk or brush our teeth or go about our daily functions. And in those individuals that are at high risk of periodontitis, the inflammation becomes dysregulated, it becomes exaggerated, and it starts to destroy the bone that holds the teeth in the mouth, and the teeth are eventually lost. And so what on the face of it may appear to be a relatively healthy mouth, the dentists and the hygienists and any specialists, oral health specialists, will note there is a kind of a marginal redness and inflammation here. But if I look and show you that patient's radiographs, the white line is where the bone should be, and the black space is where it's been lost. Fairly severe destruction happening beneath the surface. And there are various potential mechanisms, some of which have more evidence than others for this. The first one is the one I mentioned, disseminating infection, I tend to call it, and that is basically the bacteremia that develops in people with periodontal disease as the bugs enter the bloodstream. And those bugs can travel to distant sites, such as the coronary arteries, where they can actually invade the coronary arteries and induce endothelial dysfunction. They can affect other organs in the body. But I think the most important mechanism is they activate white blood cells, particularly neutrophils within the circulation, to produce oxygen radicals within the circulation and to release cytokines and various other inflammatory mediators. And they can damage blood vessels and cause pro-inflammatory and pro-coagulant effects. So you get platelet activation as well. The other mechanism for which there's emerging evidence now is what I've called disseminating oral inflammation. The inflammation within the oral and the gingival and periodontal tissues can spill over into the circulation. And then there are more complicated mechanisms that I'm not going to go into, but Graham spoke quite a bit about rheumatoid arthritis. Suffice to say that he mentioned P. gingivalis, which is an important pathogen, as Graham said, but for me, the overwhelming evidence really for the production of these citrullonated antigens that trigger antibody production in rheumatoid arthritis is the release of neutrophil extracellular traps. When neutrophils die, they're in this activated state and they release their DNA, and the chromatin backbone is highly citrullinated. and that is believed to be a major source of autoantibody production in rheumatoid arthritis. And if you think about it, you know, the swollen joint is very similar to the swollen gum or swollen periodontal tissues. And similarly, when you look at joints with patients with RA, the joint space has collapsed here. You've got erosion and destruction of bone, very similar to the picture we see with periodontitis. So is it just the bugs? And the answer to that question is no, it's not just the bugs. They're important, but they are not the only reason, because if they were, then everybody on this call would have periodontitis. 10% of you will never develop it in life. 10% of you have a very high risk, and the rest fall in the middle somewhere. But the other reason is that actually we are, as human beings, if you classified us according to the number of cells in our body or the types of cells in our bodies, we are holobionts. We're more bacteria than we are humans. And certainly when I was trained, we were led to believe we were 90% bacteria until the Human Genome Project and the oral microbiome was sequenced, and the human microbiome was sequenced, and we realized that in fact that was a miscalculation. And if you actually calculate it using modern molecular techniques, we're actually more human than we thought. One human cell to every 2 bacterial cells. What's interesting, however, is if you evacuate your bowels, you restore that balance to 1:1. So I always say this, it's quite poignant. Next time you decide that it's time to evacuate your bowels, just sit there quietly and think that you're about to restore your karma and your balance of human to microbial cells. That's slightly tongue-in-cheek. The point is we live with our bugs. We need our bugs for health, to absorb nutrients and for various other important daily functions. So actually, a lot of non-communicable disease is host-mediated. And for those of you that don't speak Greek, what this means is that inflammation is the root of all evil. And in fact, it's the bugs that stimulate the inflammation, and the various mechanisms that Graham has described as part of the disease of SARS-CoV-2, in particular the immunothrombosis, they are all effectively the result of inflammation. And interestingly, the most important periodontal pathogens are gram-negative pathogens that have lipopolysaccharide on the cell membranes, and the LPS gets into the circulation consistently. And that's been shown to bind to the spike protein of SARS-CoV-2, and it can activate the release of these nets within the circulation. And these nets within the circulation are very, very pro-coagulant in their nature, and strongly associated with a lot of the downstream lung complications of COVID-19 lung disease. So I think hopefully the answer to this question now is fairly obvious to you. These conditions all have in common the fact that they're inflammatory conditions. They're complex diseases, and that's important. I'll come on to that in a minute. But they're all independently associated with periodontitis, and they're all non-communicable diseases. Complex diseases are diseases that don't have a single cause. So, you know, something like HIV disease, for example, you have a virus that causes it, and if you can disable the virus or stop it replicating, you can treat the disease very effectively. Many non-communicable diseases, such as those in the previous slide, are far more complex, and they don't have a single cause. And so when people tell me, oh, well, gum disease is caused by plaque, my answer to that is no, that's completely wrong. It's not caused by plaque. That's what we teach our dental students. But if you think about it, it cannot be true, because we all have plaque on our teeth, and therefore we should all have gum disease, and we don't. In fact, plaque is the initiating factor of a more complex series of events. And in complex diseases, the model that I tend to sign up to is this one by Rothman, which basically says that if each of these pies, it's called causal pie theory, if each of these pies represents a different patient, then each patient has different component causes. And in order for that disease to manifest, you must have a full pie. So A, in the case of periodontitis, is the plaque. It has to be there for the disease to develop, but on its own, it's insufficient to cause the disease. D might be smoking. G, for example, might be hyperglycemia. I might be stress without coping behaviours. There are various component causes, or risk factors is the other term we tend to use, that when they come together will manifest as the disease. but the different component causes will be different from one patient to the next. And I think that's a really important concept that I'll come back to at the end. So Graham showed you this slide and referenced the Montserrat study. We're now over 60 systemic conditions independently associated with periodontitis. And a couple of years before this, I was asked to write an editorial to flag the periodontal systemic links to general medical colleagues who read the BMJ. And I'm not convinced I was particularly successful in doing that. But I think The Economist, who published this white paper 6 months ago, were a hell of a lot more successful in defining what the really quite huge societal and economic costs are of periodontitis. All diseases remain the most common diseases of humans, and in fact they are responsible for more years lost to disability than any of the 363 other human diseases that were assessed in the Global Burden of Disease study in the Lancet back in 2017. So what are the hypotheses? There are two broad hypotheses for this relationship. The first is the common risk hypothesis. In other words, people who are genetically or due to their lifestyle or the environment that they live in predisposed to producing too much inflammation are likely to be at risk of all of these non-communicable diseases that have inflammatory components to them, and therefore the association, if you like, between periodontitis and these other non-communicable diseases is down to the possession of those common risk factors, and that periodontitis is not part of the causal pathway of these other conditions. There is another hypothesis that I like to call comorbidity and cumulative damage, and there is more and more evidence emerging for this. And Graham mentioned CKD, or chronic kidney disease, and I'll just share some data with you from Praveen Sharma, who's part of my team, and this was from his PhD, and this was a large epidemiological study based on the NHANES data set in the United States that looks at survival over a 10 to 15 year period. So your y-axis is survival using the Cox's proportional hazards regression modelling, and the x-axis is time. And if you have chronic kidney disease, then your increase in 10-year all-cause mortality risk is 32%, and 16% for cardiovascular related mortality. If you have periodontal disease or periodontitis as a comorbidity, then you see a further increase in all-cause 10-year mortality of close to 10% and 6% in cardiovascular mortality. Now, you might ask, well, you know, how significant is that clinically? Well, if I, instead of periodontitis, put a blue line in that represents the comorbid impact of having diabetes and chronic kidney disease, you can see it's almost identical. You can almost superimpose the lines. But unfortunately, many of these chronic kidney disease patients have multimorbidity. They have all three of these conditions, and there aren't many left alive at the end of that 15-year period. So this concept of multiple inputs to that inflammatory pathway, I think, is a really, really important one. So we also have a longitudinal cohort in Birmingham with chronic kidney disease, and we've been monitoring them for almost 10 years. We had just under 800, and almost 500 have sadly passed away now. So we have hard endpoints for this this study, not for the best of reasons, sadly. And the reason there's such a high mortality rate is that we recruited people who were in stage 3 to 5 CKD, so they are at high risk of progression to end-stage renal disease. And we've measured their kidney function using estimated glomerular filtration rate, and we've used pulse wave velocity to look also at their vascular stiffness. But I think one of the most startling statistics that came out from this early on was a prevalence of periodontitis of 81%, and 15% have no teeth, and many of them will have lost teeth due to periodontitis. Therefore, over 90% will have experienced periodontitis, more than twice that of the general population that I mentioned to you earlier on. And when we look at the periodontal status of these patients, and here we've used a measure called probing pocket depth against their EGFR, you can see that there's an indirect and significant relationship. The deeper the pockets, the gum pockets, the poorer the kidney function. And when we look at vascular stiffness, there's actually a positive correlation. The more severe the periodontitis, the stiffer the arteries. And we've not just used pocket depth as the only outcome measure. We've also looked at various other outcome measures that I won't go into in detail. I'll just mention PISA here. This is a measure of that exposed connective tissue that I showed in the cartoon slide. So this is a measure of the wound size that's exposed to the various microorganisms that get into the bloodstream. And there are other outcome measures here, but it doesn't matter what your outcome measure is, there is a statistically significant relationship between periodontitis expressed as any of those outcome measures and poorer kidney function. And when we look at vascular stiffness, it's exactly the same pattern. It doesn't matter what your outcome measure of periodontitis is, we still have a significant relationship. So when we try to establish causality, you have to go through a number of steps here. You have to undertake the big epidemiological studies that I've mentioned. You also have to look at biological plausibility. In other words, what are those mechanisms and what's the evidence base for them? How likely is it to explain that relationship? So what do we know about cardiovascular disease and periodontitis? Well, the systematic reviews and a joint workshop held with the World Heart Federation and the European Federation of Periodontology have summarized the outcomes of the research so far. And those conclusions are that there are consistent and strong epidemiological links that periodontitis increases the risk of future atherosclerotic cardiovascular disease, and the impact of periodontitis is biologically plausible because of that the oral vascular route. And we have animal studies that show when you treat the periodontitis, you can improve cardiovascular function and endothelial dysfunction. And there's also evidence from human studies for improved surrogate outcomes in terms of endothelial function and vascular stiffness when you treat the periodontitis. And the message really is about bacteremia, low-grade chronic bacteremia, activating an acute phase response, the effects of those bugs on the endothelium, and then the relationship between the size of the periodontal wound, the amount of periodontitis, this is a diabetic leg ulcer, but it gives you an idea, which is around 5 to 20 centimeters squared, which is quite a significant area of exposed connective tissue that the oral biofilm and there are literally billions of bugs. It's the second most complex biofilm in the body, can enter the bloodstream through. So you have this sort of low-grade chronic inflammation in people with periodontitis that is happening all the time. So we got together with the World Heart Federation in 2019 and systematically reviewed the literature, and it was really quite remarkable. This group were incredibly switched on. In fact, the cardiologists read the Journal of Clinical Periodontology probably more than I do. And the look on my face here is one of incredulity, because these guys were so passionate, as Graham is actually, about the need for diagnosing periodontitis in cardiovascular patients, but also for the oral healthcare team to be checking blood pressure. And we're smiling because I did have to explain that the white coat syndrome in the dental surgery is probably worse than in medical practice. So having the oral healthcare team check blood pressure might not be as accurate as they would think. But guidelines were produced as a result, and those guidelines hopefully will be actioned in the near future. What about diabetes and periodontitis? There's more evidence for diabetes and periodontitis than there is for cardiovascular disease. And the importance of diabetes and periodontitis is acute, really, because of the situation with the prevalence of diabetes in the world at the moment. This image shows the United States of America back in 1994. And if I just scroll through in time, what it shows you is the percentage of adults in each of those states that have type 2 diabetes. So the cream is just under 4.5%, but as we progress through the years, we end up with orange between 4.5% and 6%. And then we end up with dark orange, which is 6 to 7.5%. And then we run out of dark orange and we start with the red, which is equal to or greater than 9% of the population of that state in the United States having periodontitis. And the most recent data, I think this takes you forward to about 2013. The most recent data is that well over half of the states, the United States, have type 2 diabetes levels of 10% or more. So it's epidemic, and it's in fact pandemic. Now the situation in Europe is not much better. 52 million people with diabetes in Europe, predicted 70 million by 2035, and 8% of that, that's 8% of the European population. But perhaps more importantly, 17 million cases are undiagnosed, and these people are walking into dental surgery, sitting in chairs, undiagnosed, and yet they have signs in their mouths of undiagnosed hyperglycemia, which the oral healthcare team need to be tuned into. So this workshop between the European Federation of Periodontology and the International Diabetes Federation actually produced guidelines. Please don't try to read this, it's a bit small, but the guidelines were produced for patients within a physician's practice in the waiting area. The guidelines were also for the physicians themselves, then also guidelines for oral healthcare professionals themselves, and then the fourth set are for patients in the waiting room of a dental practice. And they're fairly straightforward, simple guidelines. So what does the epidemiology tell us? Well, we know that severe periodontitis is significantly associated with glycemia. That's in people who don't have diabetes. But in people who do have diabetes, severe periodontitis is also strongly and significantly and independently associated with hyperglycemia. There is a dose response between the two, and there's a direct relationship between the severity of the periodontitis and complications, particularly cardiorenal complications of diabetes. And there's now emerging data from a number of studies showing that severe periodontitis is associated with an increased risk of developing type 2 diabetes. So what about causality, and what about intervention studies? We need to be very careful how we interpret the literature that's out there. This is an editorial we had to write essentially about the most expensive study run in the US in oral health and systemic disease, cost $15 million and was a complete unmitigated disaster, because in fact at the end of the intervention, which was the periodontal treatment, the patients had more inflammation and they had more plaque in their mouths than at the start of the study, which meant that for whatever reason they didn't have their disease appropriately treated, and so it really showed no effect. So I think we can only conclude from that very expensive study that set the oral systemic research field back in America by several years, that poor periodontal treatment has no effect on HbA1c. If, however, you look at all the other randomized controlled trials that are out there and you systematically review the literature and do a meta-analysis, even if you include that failed study, then you find an average between 0.3 and 1% reductions in HbA1c with periodontal treatment. You also see an improvement in cholesterol. The HDL, which is the good cholesterol, increases, and the bad cholesterol, the LDL, decreases. You see reduced cardiovascular complications and reduced renal complications. And also periodontal therapy does appear to have a dose response effect. In other words, the more successful the periodontal therapy, the bigger the reduction in HbA1c. So I think we need to be very careful how we interpret what we read in the literature, sadly, even if it's published in the Journal of the American Medical Association, which it was. This is perhaps a better study, not quite as big, but this was published in The Lancet just a few years back, and this was an RCT looking at, it was a 12-month study looking at HbA1c as a primary outcome. The test group had intensive periodontal treatment, and the control group had what is called community care, which is not very good periodontal treatment, unfortunately. And what it actually demonstrated was that there was a significantly improved reduction in HbA1c, around 0.6% in the intensive treatment group relative to the control group. And just to put that in perspective, that is around the same effect you'd get from a second drug in a metformin regime. And if you ask people with diabetes if they would rather have their mouths treated for their periodontal disease or go on to a second drug, certainly our PPI groups always tell us, oh, treat my gum disease, please. I don't want any more drugs. So let me finish off with just an indication on causality. I mentioned at the very beginning the fact that when the bugs enter the bloodstream and they activate white blood cells, you get oxygen radical release. And those oxygen radicals can oxidize various lipids and various proteins as part of a process called oxidative stress. And if we measure the oxidized proteins in the form of protein carbonyls, or the lipids, the oxidized lipids in the form of isoprostanes, then we can do that in the bloodstream of our 770 chronic kidney disease patients. And again, we can look at the relationship between the severity of the periodontitis, here expressed as pocket depth, and the oxidized lipids. And there is a significant relationship. It's even more significant when we look at oxidatively damaged proteins, as you can see here. And again, that's pocket depth, but it doesn't really matter what your outcome measure is of periodontitis. These are our F2 isoprostanes, or oxidized lipids. These are our proteins, or oxidized proteins, and we have a significant relationship in terms of oxidatively damaged lipids and proteins according to the amount of periodontitis. So what we've sort of summarized so far with our studies on chronic kidney disease is that periodontitis severity is associated with reducing renal function, increasing vascular stiffness, and increasing oxidative stress. And so if we go back to that sort of causal pathway that Graham alluded to, with periodontitis on the left and mortality on the right, then the most likely explanation is that that relationship is mediated through systemic inflammation, and oxidative stress is one of the most likely mediators. And that may then manifest through the changes in renal function or the changes in vascular health. And I'm going to finish with a very complicated slide that I'm going to rapidly simplify for you. This is basically showing you on the left-hand side the exposed wound area, the size of the periodontal wound. It's called a PISA score. It stands for periodontal inflamed surface area. And on the right-hand side, we have renal function. And then at the bottom here, we have all the common risk factors that we have to control for in our modeling to show a relationship between these two. So I'm going to take those out because the data I'm going to show you now has controlled for all of those common risk factors. And we've looked at the direction of periodontal inflammation to kidney failure, and we have measured an acquired immune response by measuring the production of free light chains here in blood. This is a measure of the plasma cell response. And we see no relationship between the size of the periodontal wound and the free light chains in serum. There is, however, a relationship between the free light chains in serum and kidney failure. This is a long-established relationship. But actually, when you look at that overall pathway, there's no significant relationship between the inflamed periodontal tissues and the kidney failure through that acquired immune response. What about C-reactive protein? We know that periodontitis is normally associated with elevated CRP levels in blood. In the kidney disease cohort, we don't see that. And the reason we don't see that is because the amount of CRP elevation from their kidney disease swamps any small effect coming additionally from the periodontitis. So we do see a significant relationship between blood CRP levels and EGFR, but overall the relationship from the periodontitis to the EGFR pathway is not significant. So the final thing we then modeled was the oxidative stress, and what we found here was there was a highly significant relationship between the amount of periodontal inflammation and the oxidative stress in blood. There is also a significant relationship between that oxidative stress and the EGFR, and overall that pathway is actually significant. So this is really the first evidence, albeit from a very large cross-sectional cohort, but you can, using this modelling, it's called structured equation modelling, you can in fact infer causality. And that's what we have done with this study that was published just last year. So to conclude overall, periodontitis is independently associated with all-cause and cardiovascular mortality. And the mechanisms appear to include disseminating infection, as well as systemic inflammation and immunity, and certain more complex mechanisms that I've called immunological memory. And certainly in chronic kidney disease, evidence is emerging for an indirect pathway of causality from the periodontitis to the poorer kidney function mediated through oxidative stress. So Graham, Sarah Hurley acquired the expression time to put the mouth back into the body from a paper I wrote many years ago. That was the one in the BMJ I showed you in 2014, but she's absolutely right in that we need to reconnect. And I am incredibly impressed by the work you guys are doing in Salisbury, and in particular the work you're doing, Graham, to try and put the mouth back in the body. I'm going to stop at that point, and hopefully I've clawed back a few minutes and brought us back on time, and we can move on to the QA session. Thank you for listening.
Iain, so firstly, just kind of a big thank you for kind of your presentation. It was fascinating, and certainly somebody that's actually done a lot of immunology in the past. Actually, it was kind of very insightful. So, I mean, my question was basically kind of really was, you talk about kind of the links between heart disease, obesity, diabetes, and one of those things which always kind of, for me, is always associated with poor diet. So it was trying to understand basically what are the links between poor diet and those three conditions, and how does that link with periodontal disease? And I guess my other kind of concern was you talked about fatty streaks, but actually when I was at medical school, we learned that fatty streaks are occurring in adolescents and people in their early 20s. So what can we be doing in order to actually kind of prevent those in that young age group?
Fantastic question, Zoe. The nutrition one is really interesting. We've done a lot of work on this because I'm, my benchtop science is neutrophil biology, and in fact, what you find is that there are two reasons that the diet's problematic, and it's the sugar more than the fat actually, because the refined carbohydrates, of course, drive. I'm sure you all remember Krebs cycle and the inner mitochondrial membrane. And the maintenance of the proton gradient across that membrane is through the electrons passing through their carriers, those flavour proteins. But that system is not 100% efficient, and you get electron leakage, your complex 3. So when we're trying to produce ATP in the mitochondria, we're actually releasing electrons that then oxidize oxygen within the mitochondria to form the superoxide radical, which causes mitochondrial stress. So if you then increase your refined carbohydrate intake in your diet, it drives that even more, and you end up with oxidative stress, oxygen radical release, and inflammation as a result. So that's a fairly key pathway. It's called meal-induced inflammation now. It's a recognized term as of, I think it was back in 2016. Helmut Sees, who first described oxidative stress, introduced the term meal-induced inflammation. Whereas if you actually have a diet that's very high in polyphenols and in micronutrients, antioxidant micronutrients, and all the cofactors that go with that diet, so a Mediterranean diet, then you quite clearly drop the blood sugar levels after you eat a meal dramatically. You can actually measure, there's some two wonderful studies from Warwick by Antonio Cerrillo it was, and his group, that show that if you measure carotid intermediate thickness after you eat a meal, it increases transiently after you eat a meal due to that meal-induced oxidative stress. If you then actually load yourself up with micronutrients, actually you see less of a thickening of the carotid intimate media after you eat a meal. And these are transient things, and they're related to the size of the spike, so the amount of sugar you're eating, and also the frequency of sugar intakes, so the number of spikes. So if we limit our refined carb intake to meal times and don't snack between meals, that's a really positive thing to do to reduce inflammation in the bloodstream and the vasculature. Now, you're absolutely right. Modern imaging techniques, and Graham will know this far better than me, do in fact show atheroma start to develop. I think it's from the age of about 9 or 10, which is really quite scary. And so it's a very long-term chronic process. So you're absolutely right. What we can do about it is we can educate children in oral hygiene. We can educate children in exercise. We can educate children in better diets to try and slow down that process. I often say to people, how many people are over the age of 40 in this audience, and all the hands go up, 50% the hands go up. Well, you're all in kidney failure because our kidneys start to fail from the age of 40. Well, we start developing atheroma from a much younger age, but we can slow that process down. So it's that behavior change, it's that environment that really translates the genetics, as I said at the beginning. So excellent questions, and I hope I've managed to answer them in part.
Absolutely fascinating. And I think the final question was, is there any Mendelian randomization studies to confirm the links between periodontal disease and atherosclerotic disease?
Yeah, so there are some genome-wide association studies, and there has been one common genetic locus that's been identified, but I must be honest, the evidence is not that convincing. So I don't think it's pure genetics. I think it's more about lifestyle and environment and the translation of that genetic code than it is a particular SNP or a particular genetic predisposition.
Thank you very much, Iain.